Presenting today a CLI case, which I call Caput Medusa. For those who don't know it, it's a Greek creature shaped as a woman. I don't have any issues with any woman, but it basically, when you look at it and you gaze into it, it turns you into stone, and I'll show you why. So this is a 60-year-old male, the history of diabetes, hypertension, hyperlipidemia, presented with bilateral breast pain, much worse on the right than the left. Diabetic, not very well controlled. Lipids are not LDL on the higher side. Kidneys were okay. He is on aspirin, stan, atorvastatin, celestazol, and insulin, so reasonable medication. Vascular studies, essentially ABI, show that they were pretty significant. Ultrasound essentially shows biphasic to triphasic in the common femoral SFA going down, but at the popliteal we saw monophasic waveform. A CTA lower extremity showed that the iliacs were free of disease, and it showed that there was no discernible opacification of the trifurcation of the vessel. So we brought the patient back and essentially started with antegrade access, especially that the iliacs were kind of occluded, and we're dealing with a BTK case here. So this is the first picture, as you guys can see. Essentially the SFA looks like it's free of disease, no issues. And this to me looked like the Caput Medusa, right? When you look at it and you're like, wow, this is, I don't see anything kind of going down. I don't have any antegrade options at this point. There may be a hint of a perineal going down. However, when you actually take it a step further, I think that perineal is most likely could be a collateral. So we're not really sure. No AT or discernible. The next picture, which essentially shows the distal calf, here we see some reconstitution, mainly through the perineal, the anterior and posterior communicating arteries, and patient had a reasonable kind of pedal loop, slow flow, but essentially it kind of fills up through a perineal. So at this point, when you look at this picture, there's a lot of kind of decision making that goes in. The first one is, you want to do no harm in this patient. Remember, he's only rest pain. So one option is to basically try to go through that, what you think is the perineal. If it's a collateral, you could get yourself in trouble. The other thing is, if you, for some reason, you go in through that perineal and you compromise it, then you just could turn this CLI into an ALI patient. So you got to be very careful. I do not see an op for the AT, bunch of collaterals, same with the PT. So it's a really challenging case. But when you look at the foot, I think that's your key to kind of helping this patient, is that you see that he's got a reasonable AT and dorsalis and PT. So those kind of were the thought process. I did not want to kind of poke around with those collaterals because you might give him a hematoma or cause him to bleeding. That was not a good option. I did not want to go after what I thought could be a perineal, because if it is a perineal and you compromise it, you've turned it into an ALI. If it's not a perineal and you're in a collateral, then you've caused even more trouble, right? Because now you've got bleeding all the way. So at this point, my decision was essentially to do like what I call a rendezvous technique. I take another picture here to take a look at it, and I really don't, like I'm with a catheter all the way down in the tibial and DSA to see if I see anything that I can poke at anteriorly, and I really was not comfortable in any going through those. So what I did at this point is basically chose to go with a pedal axis through the dorsalis pedis. Some of the tricks that we used when we used the dorsalis pedis, there's a described technique called the JENALI technique, and essentially once your wire hooks into something and tries to loop, you start kind of twerking that wire, and what happens, that corkscrew effect will try to keep you within the vessel and will give you kind of enough force to try to get you up there. The danger if you just use a straight wire is that, especially with the AT, you got to be careful. When you're trying to go around the loop, sometimes the wire, especially if you're using a pretty stiff wire, might just go through. So using the JENALI technique kind of helps you stay within the vessel and will give you enough kind of support to sort of puncture that distal cap or whatever cap you're dealing with. So after we kind of got it, we were able to kind of go in. Next step was kind of flossing. So this is a 035 catheter from above, and then a 018 catheter from below, and basically you put them and then you floss a wire. The beauty of flossing is that it gives you a lot of control right now. So you got a micropuncture sheath from the pedal, and you have an antegrade SFA. You got a flossed wire, so basically you got a ton of control. You can do your IVUS atherectomy and what have you. So we went ahead, essentially like every case, we start with an IVUS, showed a ton of calcium. We chose to do CSI in this case, and then this was followed by kind of sequential balloon angioplasty with long balloons, slow balloons, and kind of we got fantastic results in the AT. So now at least we got the patient AT. Of course, patient symptoms kind of improve, but he still comes back and he's asking for, if we're able to do anything else for him. So we brought him back, and here I see a knob. So we take him back. The AT is nice and it's flowing, but then I see a knob. And in this case, then I was comfortable actually to go antegrade in this case, because remember the first one, you basically bunch of collaterals, you don't have any knob. Here it's a much more favorable cap in the C-top classification. So with a combination of an O3 micro catheter with an O18 inside that, O14 inside that catheter, I was able to wire all the way down into the lateral plantar. So the 035 kind of gets you towards the mid-calf, and then the 014 inside it takes you all the way down. And then within those two catheters, now that I know that I kind of got access to it, next thing is basically IVUS, which again showed a lot of calcium. We did atherectomy, and then that was followed by sequential balloon angioplasty. And these are our final results. So as you can see, we've kind of restored his AT, we've restored his PT, and if you play this, the flow is so much kind of brisker right now going to the foot. His symptoms significantly improved. With this, I would like to thank you for your attention. Any questions? All right.
Go ahead.
Very nicely presented. I guess my only question is, can you explain a little bit more about the second intervention? So it seemed like you had a pretty good result from the first intervention. You got AT inline flow all the way down to the foot. So what was the rationale for treating the perineal?
This is
typically, what's your algorithm for treating more than one tibial vessel?
That's a good question. So in this case, his rest pain improved, but it was not completely resolved. So he brought back. And, there's some people do 2 arteries or 3 arteries. I usually try to keep, if somebody has CLI, to at least give them 2 below the knee vessel arteries.
Thank you.
Okay.
When you have an ulcer, I understand the ABI is not very credible. But when you have rest pain with an ABI of 0.6, I'm wondering if he had coexisting neuropathy. Because even for your second time when the patient came in, you said claudication, right?
Rest pain.
Usually, rest pain or persistent rest pain. Yeah, I'm wondering if you're maybe not treating the right disease. Maybe he's got underlying neuropathy or something. Because just with an ABI of 0.6, it's difficult to believe that his rest pain or his pain was predominantly from vascular disease.
I agree. I think it's always challenging to know what's
you're right.
what's causing the pain, because he was actually presented to the ER and he's like, I can't stand it. I'm not able to work or do anything. So he was treated for his neuropathy. But it's always challenging that, is this PVD, is this neuropathy, or is this both?
Thank you.
Did he get better after the second
I was gonna
intervention?
ask.
Yes.
Yes, he did.
Yeah.
That's the
All
right
right.
answer.
Yeah.
Okay.
Thanks, guys. Significantly better.
Great.
Good job.